Good morning, everyone. We're going to give just a few more minutes for people to get logged on. Good morning, Dr. Stull. Okay, good morning, everyone. We're going to go ahead and get started. My name is Sarah Aminirad, and I am the PBRN coordinator with DO-Touch.NET. Thank you for all of you who are joining us for Let's Talk About OMM Research. Before we begin, let's take a moment for the housekeeping rules of the webinar. Please add your name and location into the chat so that all participants can see who's attending the webinar. If you have registered for CME credit, you must add your name in the chat to verify your attendance in order to receive CME credit. Additionally, you will need to complete the physician attestation form, which was emailed to you this morning, and an evaluation survey, which will be emailed to you this afternoon. The Let's Talk About OMM Research Planning Committee has no conflicts of interest to disclose. If you have any technical issues during the webinar, please send a message to me or Jane Johnson. If you have any questions or comments during the webinar, please put them in the chat and feel free to address each other's questions and comments there as well. After the presentation, we will have time for discussion and questions. If you would like to speak during the discussion, please raise your hand and we will unmute your microphone. We ask that you briefly introduce yourself, but please limit your time to 3 minutes to allow everyone to participate if they wish. Please keep in mind that this webinar is being recorded and will be placed on the DO-Touch.NET website, where you will have the opportunity to continue the discussion. We will send you an email announcing when this recording and discussion are available. Now, please help us welcome Dr. Chelsey Stull, who will be speaking about the journal article, Overcoming Placebo-Related Challenges in Manual Therapy Trials, the What's and How's and the Touch Equality Assumption Proposals. Dr. Stull is currently a resident at Northeast Regional Medical Center in Kirksville, Missouri, in the Neuromuscular Medicine +1 program. She attended the Family Medicine Residency Program at Franciscan Health Olympia Fields, as well as the OMM Pre-Doctoral Fellowship at Des Moines University. Dr. Stull also participated in a medical acupuncture program at Helms Medical Institute, was a lecturer at Feely Ltd, and a research assistant at Eastern Washington University. She is well versed in lecturing, curriculum development, and research. There are no conflicts of interest to disclose. Please help us welcome Dr. Chelsey Stull. And the floor is yours, ma'am.
All right, thank you very much. I'll just share my screen here. All right, so as Sarah, thank you, Sarah, for that introduction. The journal article I picked today was Overcoming Placebo-Related Challenges in Manual Therapy Trials, the What's, How's, and the Touch Equality Assumption Proposals. This was from the International Journal of Osteopathic Medicine in 2021. And I picked this because a big struggle in osteopathic trial development is deciding on what type of placebo you would use and how to make it most effective in your research. So I have no financial disclosures. I'm just going to minimize this window here. So we're going to review and discuss current methods of placebo use in manual therapy trials, and then discuss what the paper proposes as the touch equality assumption, and then further go into what they propose as the what's and how's presented in the journal article. The article starts out with talking about the difficulty to define the placebo concept. And this is due to several different models. We can have neurobiological or clinical, pharmaceutical, and then different contexts. So just a drug trial in itself, a psychotherapy, alternative medicine or complementary, and of course, manual therapy trials. Excuse me. And then there has been difficulty in describing placebos as well, because there are different ways in determining and describing the placebo. We can decide whether it's effective or ineffective. So we would use a placebo that we know isn't effective to test something that is effective, or something that's active versus inactive. So like using medication that is active and then using a sugar pill that wouldn't have the same effect. Or what the paper describes as something that's been newer in randomized controlled trials as specific versus non-specific. So the paper proposes that specific refers to the therapeutical component included only in the intervention arm of the trial. So in this way, the trial is measuring something very clear. It's a specific therapeutic modality only in the intervention arm. And thus, the placebo can do anything else because it's a control lacking against the activity that they are testing. So that is then determined non-specific. In the past, manual therapy trial placebos have been examples of detuned ultrasound, placebo pills, random light touch, many others, and that conclude things like magnet therapy or more firm touch, but in different areas of the body. The paper describes 4 issues that have been difficult in the past for using placebos in manual therapy trials. And it discusses how these specific, non-specific concepts can clarify these 4 issues. So the first issue it points out is that a sham protocol with the specific, non-specific verbiage no longer needs to be considered ineffective to be used. It only must be non-specific. And then the number 2, touch is considered a non-specific manual technique in general. Then the sham therapy should mimic the real intervention to best demonstrate the impact that the actual specific manual technique will have on the trial. Placebo in treatment should similarly match in non-specific features of touch. And so this is talking about multiple studies that they reference applied non-therapeutic manual approaches in very different fashions. So in the past examples, they might use soft touch or simple gentle touch as controls for something as a high velocity technique. So something very different than the light touch itself. Or not using touch at all with the detuned ultrasound machine, which would take away the interaction of physical touch at all. So when we match the placebo in treatments, it helps further delineate the actual impact that the specific treatment would have. And so things that should match is the time of manual contact, the areas that are treated, and the type of movement. The third issue is that it is not required to understand the mechanism of action of a technique, only that it elicits a certain effect. And so past arguments of sham treatments in randomized control trials is that we don't understand the mechanism of how it works, and so it makes the results less significant. But if we use the specific versus non-specific model, and we know that the sham treatment does not elicit the same effect, then it doesn't matter what the effect is or how it, or if we know how it works, but only that it's different. And then the fourth issue is questioning whether or not we can identify the specificity of osteopathic treatment, because osteopaths combined, as the paper references, long embraced an approach to patient care that optimizes patient-physician rapport and focuses on an array of psychosocial and individual health factors. And so as we see our patients in the trial or in clinic, we do combine lots of different things other than just the treatment itself. And as the paper references, no trial is in a sensory vacuum. But if we can identify the specificity of osteopathy, it becomes more relevant in how we design our clinical trials. Some definitions that the paper discusses is a single osteopathic technique, or the approach, and that is the sequential procedure applied by the practitioner in order to treat bodily areas with particular attention paid to the somatic dysfunction. And somatic dysfunction would be an area of restriction or tissue texture change that was found on the exam. A quality assumption implies that the non-specific factors are matched between control and experimental groups. And this equality assumption is assumed in all randomized control trials, where the setting and the patient's characteristics, the timing of day of treatment, all those type of things are assumed to be equal between the control and the placebo. And then assumption of specific efficacy is a measure of the effect on the experimental group minus the effect on the control group. And that is assuming that the equality assumption is true. So the paper then proposes that we can further delineate the equality assumption for randomized control trials for manual therapy. And they introduced the term touch equality assumption, or TEA. They discussed that non-specific touch has been demonstrated to cause multiple measurable changes. One of the examples they give is that sham touch induced significant short-term effects on patients' reported outcome measures in a sample of chronic migraine patients compared to treatment as usual. And then they also showed the touch sham group showed a significant smaller response compared to the treatment group. It would be therefore useful to divide touch in two components: the specificity of the manual treatment and the non-specificity of touch itself. And that will help us to further delineate the results of the treatment itself, that we're testing the specific portion, not the non-specific placebo. And the touch equality assumption should be a detailed description of the touch that is implemented. So the study should discuss the body region, the style of treatment, whether the practitioner is inducing a force or if the patient is causing their body to move on itself, or if they're just passively resting on the table. And then the type of treatment, either light touch versus thrust. And they should be any trials that are developed that do use the specific versus non-specific can use these sections here to further clarify the placebo and to match it to the control or the specific test that they're testing, this technique. So there's the type of touch, and that's important because different touch can influence the nervous system. So we can activate specific fibers or have an emotional or homeostatic response. The amount of pressure is important. Greater pressure can be perceived as more invasive or painful, and that could cause more of an effect on the response from the patient. The type of movement and patient positioning. So some techniques need the patient's active participation, and that's would induce the patient feeling control or not control for a specific part of their body. And then the areas of contact should be discussed. The head can have more of a placebo significance. And so if we were testing something, the specific treatment was on the foot, and then we used the placebo on the head, that would make it unequal specific versus non-specific. And then furthermore, there's link with the type of touch that we had discussed earlier. And then the amount of contact of the touch. And then the characteristics of the practitioner should also be the same, because as we know, how you interact with your patient, your ability to listen and to talk with them and help them feel listened can definitely impact how they perceive the treatment. So then they further go into describing how these concepts that we discussed can apply to every paper that's reported. And they break that down into the what's, the how's, and the how not to. So the what's they describe as the intervention, the characterizing elements, the patient's, the need-based treatment or treatment protocol, the concept of barrier or neutral point, the level of attention that the provider is giving, and the somatic dysfunction that will be addressed. The hows should be described how the operator performs the technique, for how long or until a specific endpoint, and then how their operator tailors the clinical reasoning to the patients in the trial. And then important on the placebo part is how not to do the touch or technique of the sham. So this is to ensure that the specificity in the sham technique, you're avoiding it and you stay in the non-specific region. So that maintains the equality assumption and the touch equality assumption. And they discuss several examples in their paper about different studies in the past where they have maybe described one or two of them, but not clearly described how they other portions. And if the papers do describe the what's, how's, and how nots to, they are easily going to be being able to repeat in other trials or in clinic work itself. So in the example of what is not specified, how not specified, and how not to not specified was an example where the authors only listed the techniques performed without explaining the principles guiding them or indicating how to perform them. And then regarding the sham group, the authors only stated patients in the sham OMT group received light touch at the skull and at the sacrum, with no indication about how not to touch at the skull or the sacrum. And that would be important to ensure you're not reaching the specificity of what you are testing. An example of a paper that did specify the what, but not the how or the how the not to, was where they discussed principles of direct and indirect techniques. Thus, they described the what's, but they did not report how the techniques were performed or thorough external references and did not give any indication of how to avoid the specificity in the sham treatment. Roll et al. Were able to specify the what and the how, but were unable to discuss the how not to. And they described the description of their techniques and provided references. So the entire specificity was reported, the what and the how, but they were not able to discuss the sham arm. They only stated assessing the patient's cranial rhythmic impulse, spending a similar amount of time as used for the treatment arm in the techniques. But the how not to with specificity was missing. Specifically, the strategy of how to disturb your attention or intention of the operator, if described, would be further helpful in producing the study again. And then the last subject they talked about with the OMT protocol on another paper involved the treatment of the subject's posterior cervical musculature by using the soft tissue techniques of kneading and stretching. Kneading is a technique in which a force is applied perpendicular of the long axis of the muscle. So they discuss where they are in the area, what type of touch, and then how the technique is performed. And then they describe for approximately 5 minutes. So the time is also provided. And then the provider decompress the OA. And then they further go into how that is done with using the index fingers. And then with the sham intervention, the authors indicate further delineate that the sham treatment protocol involved the placement of fingers near the condyles, and then they describe how it's different from the decompression. So no tension was applied in any direction, and the subject's head was simply held in the treatment provider's hands. So this paper fully described the what's, how's, and how not to. The paper gives 3 reasons for why we should be, as a whole, in manual therapy trials using this platform for the what's, how's, and how not to. Firstly, they describe that we would be avoiding using any sham procedure to test different approaches. So that would be using light touch for HVLA, and then we can avoid using different sham procedures to control for the same treatment. And then the assumption of the touch equality assumption, we can indirectly address the credibility of the sham treatments. So if we can assume that light touch would have an effect, and we're also doing light touch in our treatment, we then can see further what our treatment is actually doing. And they conclude with implementing a thorough description of the what's, how's, and how not to will increase the internal validity of the trial and further clarifies any impacts that osteopathy may have within the trial. And further reporting on placebo procedures will help highlight any distinctive characteristics of a given manual approach and further differentiate it from other similar therapies. And those are some references.
Thank you so much, Dr. Stull.
You're welcome.
All right, so we're going to open the floor for some discussion and questions. And just a few reminders before we do so. If you would like to speak during the discussion, please raise your hand and we will unmute your microphone. And we ask that you briefly introduce yourself and turn on your camera if you wish. When contributing to the discussion, please limit microphone time to 3 minutes to allow everyone to participate. And we will also provide you a timer to help keep track of time. The moderators, which are Jane and I, will be happy to read your questions or comments if you would prefer to type them in the chat as well. So if anybody has any questions, you can type them into the chat or you can raise your hand and we'll unmute you. Dr. Stull, it looks like Dr. Dean has a question. Oh.
Go ahead, Dr. Dean.
Hi there. Thanks for the great presentation.
You're welcome.
I was wondering, and I don't know if this kind of ties in with what the article and you were talking about, but I noticed too with the what's and how's, like, I just wonder how much it plays into the research. Like when I'm training the residents, sometimes they're really non-specific with their localization. So even if they're doing muscle energy, there's a lot of variation with their technique and even specificity of, you know, how well they're doing the technique. And I just wonder kind of your thoughts and maybe the audience's thoughts on how to kind of overcome those things, or, you know, when we're reading articles about certain techniques, how do we know that they're being performed kind of at their top level, I guess you could say, you know, versus not so much.
One of the comments on the paper was on that chart was discussing the level of skill that the practitioner had.
Yeah.
So they might comment on whether residents were used, or, you know,
Oh, yeah.
depending on the level of training of the individual.
Got it. So that would be kind of reported in the study so that the reader could kind of make some conclusions about skill level and things like that. Okay, got it. Thank you.
Okay, Dr. Stull, we have another question from Dr. Zaremensky, but before you answer or have his question, can you put the references back on the screen for people to read through? All right. Okay, Dr. Zaremensky.
Yeah, maybe we could send those out as an email. That would be really nice. I had a question under light touch. It said activation of CT fibers. Could you tell us what CT fibers was referring to?
Let me see if they further delineated. I'm not sure the specific. The C fibers are usually the determining like the amount of pain, but I'm not sure the CT, what they were referencing there. The C fibers are usually the slow receivers in the brain.
Dr. Stull, I don't know if this answers the question because I'm not a content expert, but I searched the PDF really fast and it says C tactile fibers.
Perfect. Okay.
I don't know if that answers the question.
It must be the C slow fibers that are referencing the tactile sensation response.
Okay, so we have another question from Dr. Lennart. Dr. Lennart, if you want to ask your question.
So more of a comment. Amy Dean brought up a great point as far as being able to helping the resident or first people training to be specific about their treatment. And just one comment on that. How it's so important to be able to do the treatment properly and localize properly, so then you know if the patient's responding to it. Because if you've done it localized well and done it appropriately, and the body or the somatic function didn't resolve, then you can quickly say, okay, that wasn't the right approach, and shift approaches. Versus just if a person is not localized well, then they may or not get an effect and not know if they need to change what they're doing. So anyway, just a comment. Amy's comment.
Thank you.
Thanks.
Okay, it looks like Dr. Zamore also has a question.
Yes, I had a comment about just what you were just saying, Doc, about helping residents out or students and putting your hand over hand when they first start and getting to their planes together. I think that really makes a difference, and trying to show them what they should be feeling. I don't know how to design studies. I would love to, but I'm imagining that if you're having a study where you want to test a certain technique, that maybe there should be some sort of a training, like a proficiency training. Because I know that the promote study, why it was successful, was that it did have periods of checking of the skill level of the people that were performing the techniques. So that maybe that can be something to think about to add in to validate your like the person's skill. And maybe something to test. The other thing I was thinking about is a lot of times in these sham or setups with designs that they've used ultrasound as a placebo for touch. And I don't know how you feel about, or any of you feel about that being part of a study versus actually trying to define touch. And wasn't there something like back in the day where they had some kind of anemometer or something that was used to actually tell the depth or the pressure that someone's hand applied to a surface, to be able to tell the pressure that was being used to squeeze down, and they can actually test that and then really be able to define that touch. So that's about it.
I think the ultrasound really takes out a lot of component of what we do, and doesn't seem very, it's very different, I think. So what the paper was pointing out is that if we wanted to very clearly delineate what the specific treatment is versus the placebo effect, they should be very similar in how you test them so that you can really see the difference of the treatment.
Dr. Downs, I'm very glad that you raised your hand because I would like you to elaborate on your comment. Oh, you'll have to unmute your microphone.
I wasn't even going to directly elaborate on or speak to my comment, but okay. So my comment is the last patient I saw before entering the discussion today was somebody I saw for head and neck pain after motor vehicle accidents. And I ended up treating arteries of the brain, arteries of the neck, cervical vertebrae, the heart, colic cords, some scarring of the appendix, some thoracic spine segments, and so forth. So whenever I see it, I don't see anybody that I would ever feel like I was doing them justice if I saw them and just gave them one treatment for a symptom. And so for me, every patient is a clinical trial of one, that you try it and you see what happens with them. And so for me, specific technique testing is almost never applicable because almost nobody has a single somatic dysfunction that you're working to treat, and almost every symptom complex you could use to define this, a presenting symptom is going to have multiple types of dysfunctions that could cause a similar regional pain syndrome. So for me, this is always really, really frustrating. I know that you need data on osteopathy, but ethically I would have trouble in participating in such a study, because I would feel like this person's making a trip in to see me. They may be driven 20 miles to see me, and I'm going to just do one technique and send them on their way. Whereas my purpose is to try to help them out more than just one technique. The reason my hand was raised was because the how not to treat is somewhat interesting, because I hope I'm not the only person for whom this applies, but occasionally I'll start I'll identify a cranial dysfunction that I want to treat, and I'll fall asleep while I'm treating the patient. And what I sort of snap to, who knows, 3, 4, 5, 10 seconds later, the dysfunction's cleared. And, so maybe it was my intention as I went into sleep, but, I think it's a conundrum. So anyway, I will shut up and let the rest of you talk.
All right, go ahead, Dr. Stull. Do you have a response?
I definitely agree that patients have such a different history, and that no patient is the same inherently makes it difficult. And especially that no osteopath treats the same or addresses the same problem the same way. I think we all feel that way, but like you said, we do need some evidence that shows that there is, an effect to osteopathy. And so, a lot of trials will make multiple treatments panels so that you could use a group of treatment or techniques to address the problem instead of just one specific technique. And if you did that, you just, following what this paper is saying, you just have to be very clear in, how you did each technique and what body region, and thus, that forward. But, as osteopaths, where we see the whole patient, that just inherently makes it difficult to compare it one person to anybody else.
Okay, Dr. Brooks, did you have a question? And Dr. Nichols, I see your question in the chat. I'll ask it after Dr. Brooks.
I have a couple of comments. I certainly share the frustration about how we treat the whole person on a case-by-case basis and the tension with the scientific world. But that really is our challenge. If you look at anything else in medicine, it's not just how the patient's symptoms respond, but we have to have some sort of objective measures for what it is we're treating. And whether it's an expert or a novice, if you don't know whether the deficit in physiology was improved by your interventions, if you don't have an objective way to measure that, you're really swimming in the dark. Having said that, the NIH Center for Complementary Integrative Health and the NIH more broadly just had a symposium, which I guess they have annually, on chronic pain. And there's a big movement to start thinking about how to develop research protocols that address whole person health issues. And so there's intellectual capital starting to be devoted to this, and it resonates with osteopathic medicine in very important ways. So that symposium is available to the public, and I could forward the link to Sarah, and she can distribute it to the network if people are interested.
Yep, I can do that.
Thank you very much.
Okay, so Dr. Nichols had a question in the chat. What would an adequate control be if you were measuring physiological effects of suboccipital inhibition, gentle touch? Asking, is gentle touch that?
Yeah, one of the papers that they had talked about that did do the how not to portion correctly was they described the placebo of the occipital decompression. The placebo part was in the same region, so the physician was holding the head, light touch. The fingers were at the base of the skull, but there was no upward motion towards, or the intention of the provider was not part of the treatment. So yeah, that would be a reasonable placebo option.
There's a really great conversation happening in the chat. I just want you to know, Dr. Stull. Does anybody have any questions that they would like to put in the chat, or raise your hand and ask here? Let's see, chiropractors have physical approaches. So there's a comment that says some of the chiropractic studies have compared philosophical approaches such as few versus many interventions and protocol versus needs protocol versus needs-based. And then the question to that is, has there been any osteopathic studies of that nature? Do you know that answer? If there have been?
So the
Jane?
question was whether there's,
So philosophical approaches such as few versus many interventions and protocol versus needs-based. And that was in a chiropractic study. And so they're asking if you know of any osteopathic studies like that. Jane, do you know if there's any? No?
I do not know of any. That
Okay.
doesn't mean that there aren't.
Okay. Dr. Brooks, did you want to say something else?
I want to respond to Dr. Zaremski's comment that there are actually billions of possible dysfunctional combination patterns that could be present at any given time, which really precludes lots of realistic comparisons. Well, I think rigorously you're correct. We certainly have a rich tradition over the last century or more of discriminating the severity and possible impact of one dysfunction versus pattern of dysfunction versus another, the so-called search for what archaically was called the key lesion. And so we have to not only have more objective ways to evaluate somatic dysfunction, but also to discriminate their impact. And when we can begin to reach some agreement about that, that is to say, we can have improved reliability, then we've got something that we can hang our hat on. But until we do, we are swimming in the dark.
Thank you, Dr. Brooks. Does anybody else have any questions? Oh, Dr. Downs, did you have a question?
Yes. I was wondering how many studies have been done where you have a number of us, I know there have been study groups that have worked on this, but how many studies are in the literature that look at a number of similarly trained osteopaths or similar skilled osteopaths looking at examining the same patient and comparing diagnosis? I know it was part of like the study groups after Sutherland and that sort of thing, but I'm not sure if I've seen anything. I haven't really looked that hard in the literature in the last decade or two that would just look at the consistency of assessment, let alone the consistency of treatment technique selection and so forth.
Thank you, Dr. Downs. Dr. Zamore, did you want to respond?
Yeah, well, I know that there's not enough of what he's asking for, but I was thinking about one of the studies that I saw in the OB world, that they just took one technique and tried to use it in a scenario, a patient scenario. And then through that, I think you can look at the proficiency of using that particular technique. But it's almost as if we have to take like myofascial release. We have to take strain counter strain and put it in the scenarios like what he's saying. But through that, first you have to prove that works for that particular problem. And then you have to go back and say, okay, now that we know that, let's say I do stills for the pubes before delivery. So I know that works because I personally know it works because it works for me. But like, I don't have a study to say, hey, everybody do this. And I've standardized this, that everybody should do this before she delivers to make sure her SI joints are good and her pubes are. But now who actually knows how to do it right? And how do we equate that? That's the hard part. That's the hard part. So
it's a really valid point.
It's got to be a collaborative effort. I think great minds should think alike. And like, if somebody figures out like an awesome way to like do that for one particular technique, and maybe we can validate each of the techniques for the different, like most common things that we would use it for. And then that would be a great way to like validate the technique. And then from there can explore all the other qualitative things. And then I think that would bring up how do we teach it in school? Because I'm over here at first and second year. So like, how am I teaching it to the students on the ground level? And then how, when they take it over to third and fourth year and continue to perfect their craft, that they most likely will try to use it more when they're attendings. Because that's the bottom line. We want to be using this and making other people use it that aren't even DOs, that they want to learn how to do OMT. That's what I think the goal should be.
You know, Dr. Zamora, when I was doing rotations for students, I did rotations for first and second years, and they would go and they would do either just shadowing or they would do like a summer preceptorship program. And after their summer preceptorship program, they'd always come back and say, well, we learned it in school this way, but this person does it this way, and no matter what the treatment was. And so your comment just made me think of the numerous students I heard that comment from. So
what I feel bad about being an osteopath is you learn like standing flexion test, seated flexion test, but in clinic, you don't always have time. You kind of find shortcuts to do things. So then when students are working with you, they're like, okay, you're evaluating the pelvis. Why didn't you make them stand up? Why didn't you make them like that? I think it's really, that's bad. That's kind of bad. Because then when I have a student, I'm like, oh my gosh, let me do a standing flexion test because they're expecting me to do this. But like, I got to see more patients and like, I don't have time to do that.
right.
I find the information that way. So should we be teaching the alternative ways when they're first learning? But they need to have a groundwork. They need to have foundation. So that would take, we would need to have 5 years in medical school to do that, I think.
Yeah, that's very true. Dr. Brooks, did you, well, first, Dr. Stull, did you have any response to Dr. Zamora at all?
Several, I think what you just discussed about many of the attendees I have seen treat much differently than, you know, how we teach baseline students. You know, I think from how Stull used to teach is much different than how we teach now. And that just has had to, I think, evolve as the class sizes have increased and the amount of table trainers. And, you know, we have to give them a baseline knowledge of how to, you know, understand a body region and how to assess them. And then as we give them those tools, then they can further, you know, develop their skills, like how we use it in clinic practice. But you're right, if we had more time with the students, we could just go right into teaching them, you know, how we address a patient now. But the time is really the issue.
So if we could just figure out how to get more time in a day, that would be great.
Yeah.
Okay, Dr. Brooks, did you have a comment?
Yes, in response to Dr. Downs, there have been reliability studies done in the osteopathic profession, most notably in the early 1980s at Michigan State University, when it was a fairly new, the osteopathic college was fairly new, and a lot of the so-called best and the brightest throughout the profession were recruited there, and the studies were supervised by PhDs. And unfortunately, the reliability was very, very poor. My analysis of those studies was that a big part of the problem was that they weren't really, there was a lack of validity in that the experts weren't necessarily asking the same questions about the body. More recently, in the early 2000s, Dr. Degenhardt led a team at Kirksville to look at evaluation of TART findings in the lumbar spine. And once again, unfortunately, the reliability was way below what we would expect for other forms of physical examination other than positional changes. So this is a huge scientific challenge for our profession. And so those studies are available.
Thank you, Dr. Brooks. Dr. Zamora, go ahead.
Okay, my big mouth today. So, but you know, because I attended a grand rounds yesterday, and it was about chronic pelvic pain and just how that approach was in physical therapists. Like, I look at chiropractors and physical therapists and how much research they do and have done, and kind of validated their palpatory techniques. And so we're like 50 years behind the times of research. That's what I'm quoting from someone else saying that to me. So like, how do we do it? Because they're doing it.
Mm-hmm.
And that article comes to mind from, is it Brian Peppers that wrote that article about the NIH flow to like get a paper published or funded? That was a very interesting article about what you have to go through to like get accepted. And it just seems that also may be a block for our osteopathic research that we really should pay attention to.
Mm-hmm. Absolutely true. Dr. Dean, I just want to touch base. I've seen your hand go up a couple of times. Did you have any comments or questions?
Yes, I just was wondering for Dr. Zamore. I think from what I see, I teach more interns, residents as core faculty, and it seems like there's a disconnect in that third and fourth year when a lot gets lost. And I just wondered what your thoughts were on that and how to bridge that gap.
I'm the perfect person to ask that question because my school has started a program. Well, they changed a curriculum at OU, at Ohio University, to case-based only. And the third and fourth year, and we piloted it 2 years ago. This is the third go around for the whole curriculum, but I am the instructor of the site of the Columbus site for the third and fourth years. So I am now, this last time was my second time having a whole year where the third and fourth years would come off their rotation one Friday a month. And we have residents from family practice residencies also come be table trainers. And we have a curriculum where, and I'm happy to share this. And we have a curriculum where we go through different case scenarios. They get a kind of a grand rounds introduction to those questions and cases, and they have to answer questions to pass a test, 10 questions for each. And then they meet with their small groups in the different, we have 3 different locations, and I'm the one for Columbus. And so that's an opportunity to have them get checked off of their skills that they had to learn. Let's say if it was a pneumonia case or COPD, we go through all the techniques that they might have been introduced to in their first and second years, but now we're giving it clinical relevance. We do go around the classroom and ask if who has, that's how I start class, who's done OMT since the last time I saw you? And then they get to talk about their cases and we can talk about it. And then that's when the residents come in and jump in and say, hey, this is another way to do this, same technique. And I think that's what enriches the growth and it keeps the students still involved. So I love it. I love being a part of it. I can see students grow. I don't have separation anxiety when they go off to their third years. So it's really awesome. It's really awesome.
That's great. Thanks for sharing that.
You're
Super
welcome.
cool.
Does anybody have any final comments or questions at all? Dr. Stull, did you have any final comments or questions at all for anybody?
Really appreciate everybody's input, and I think we all have main desire of furthering osteopathy, and I love that you guys are helping the residents and students, and that's a great idea. I'm just joining faculty at AT still, and so I definitely, as a family medicine resident, I use it a ton in my clinic, and I am hopeful to engage the students more in the disconnect between learning it in lab and the difference it is in applying it in the clinic. And that's something that I'm hopeful that we can further as a community and our colleges as to how do we apply this clinically.
Yeah. Dr. Zamore, did you want to say something?
I say, someone asked me, a few people asked me, Dr. Z, how did you incorporate OMT into your OB practice? So they're expecting this one-liner. I say fear and necessity. Like you just have to get one bad shoulder dystocia to you know what? I need to make sure those SI joints like really fluid. I need to make sure that there's enough space, and that makes you go back into your anatomy books. And so I think it's just the questions that you ask yourself, but your goal is to have improved patient care. And I think that's really what should drive someone to really want to seek out the need for it. And also, I was the only osteopathic doctor in where I first started practicing. So I'm in this big group and I'm the only DO, and they're like expecting something too. So like, okay, I need to bring some skills forward here. I have to represent my crew here with osteopathy. So I have to do some things. So that was also part of it, to just show off what we do and the difference.
I just want to make a plug really quickly. So there's a comment in the chat that says, we DOs have focused on treating patients and not worrying about doing research. All of my patients know it works. And that's wonderful and that's great. And we all sitting on this call know it works. But that's what DO-Touch.NET is for, is to help you do research. And so I just really encourage you guys, if you're interested in doing research, to utilize us. We can help you do the research. We can help with the IRB. We can help with the stats. We can't do the hands-on stuff. You guys do that, but then we do almost everything else. So if you guys have interest, utilize us. And then just on behalf of Dr. Dagenhart, who's actually on vacation, I just want to thank you guys for coming today. This has been a really great conversation, and this is going to be, this is going to be recorded and put on the website, and I will send you guys an email when it's available so you guys can continue the discussion on the website as well. Thank you guys so much for coming.
Thank you.